Hello guys, welcome to this new video. Today we will speak about arrhythmias, one of the important topics in Krok 2, and there are many questions that are coming about it recently. And also it's challenging because there are a lot of information about the treatment and about how to diagnose arrhythmias. There are many arrhythmias. Today we will take one of the most common arrhythmias that come in Krok, including paroxysmal supraventricular tachycardia, ventricular tachycardia or paroxysmal ventricular tachycardia, atrial flutter. These are considered all arrhythmias that cause increased heart rate. Also we'll take heart blocks or atrioventricular block, especially complete heart block, and extrasystoles, atrial fibrillation. So before we start, what are arrhythmias? These are problems with the conduction system of the heart. So the conduction system of the heart, as you know, start with the SA node, sinoatrial node, which determines the heart rate for the whole heart, and then it sends impulses to the atria, and then the impulse reaches the AV node. And then the AV node sends the impulse through the bundle of His and then to the Purkinje fibers, and then the ventricles are depolarized. So this is the conduction system of the heart. It's basically the electricity of the heart, and when there is something wrong with it, we have arrhythmias. A normal electricity of the heart will make for us the normal ECG, which we all know from physiology of the second year. This is PQRST, right? So this is the normal. Let's start with the first arrhythmia for today, which is paroxysmal supraventricular tachycardia. And from its name, it's a arrhythmia that's starting in the atria, right, in the supraventricular area, either the atria or the sinoatrial node. So there, the problem is there, and the etiology is a reentrant tract. So this is just for general information. For when you see the word paroxysmal, then the heart rate will be between 150 to 250. It's always like this in these questions. So when you see the heart rate between these two numbers, 150 to 250, think about paroxysmal tachycardia. And for the ECG, because of it's a arrhythmia that starts in the atria, so we will have abnormal P waves. So there will be, for example, ectopic P waves or extra P waves. As you know, P waves represent the atrial depolarization. So this is the heart. The paroxysmal supraventricular tachycardia starts here, right? And there is the P waves that are ectopic will be represented in the ECG. While the QRS complex is normal, because this is a arrhythmia that starts in the supraventricular area in the atria, while the ventricles are not involved in this case. Sometimes they will tell you that P wave overlaps with T wave, so it means that, for example, see here this ECG. This was going normal, regular, or regular. For example, we have here the P wave, right? And then QRST, then P, QRST, and so on. And when the supraventricular tachycardia starts, we start seeing the heart rate getting faster. The interval between the QRS complexes is less, so it's a faster heart rate. And we start to see that there is P, QRS, right, and then P again, okay, or slight T wave, and then sometimes the T overlaps with P wave because it's a very fast heart rate, and the T will combine with the P wave. So sometimes you see that in the question, so you're wondering what is this. It means that the P wave is like a fast heart, due to the fast heart rate, the P wave overlaps with T wave. Let's see an example. A newborn infant has mild cyanosis. etc. And then they tell you the heart rate is 230 beats per minute. And as I told you, when you see that the heart rate is between 150 to 250, think about paroxysmal atrial tachycardia, and this is the right answer. Right. For the other options, we will see why they are not true in later questions. We will explain other arrhythmias as well, like number C. Let's take another example to make it more clear. Then here we see that the pulse, for example, is 185 beats per minute, and this is between 150 to 250. So think about paroxysmal tachycardia. ECG taken during the attack shows ectopic P waves. QRS wave is not deformed. So they are telling you it's not a ventricular arrhythmia. They are telling you it's an atrial paroxysmal atrial tachycardia. Sinus tachycardia, it's tachycardia that is between 100 to 150. Paroxysmal atrial tachycardia will be 150 to 150. Paroxysmal ventricular tachycardia, we will see it now. It will be also between 150 to 150, but in this arrhythmia there is ventricular arrhythmia. So the QRS wave will be widened, they will call it widened. And the P waves will be normal. But in atrial tachycardia, the P waves will be ectopic and the QRS will be deformed. And atrial fibrillation, there we will have flutter waves. Sorry, not flutter waves. They will call them fibrillation waves. We will see them. They are small, unevenly sized P waves, right? Not ectopic P waves. So small, unevenly sized P waves. We will see them. There are multiple P waves, not only one, like we saw in paroxysmal tachycardia. There are multiple P waves like this, and then after that we have one QRS. While in paroxysmal tachycardia we have just P waves, then another P wave, right? See here another example. ECG shows that heart rate is 240, so between 150 to 150. P waves overlaps with T wave. We explain why this, because the P wave is like occurring at a faster rate. Lengthening of PQ interval, QRS complex without changes. So it's a paroxysmal atrial tachycardia. For the questions about the treatment, let's see it. The treatment for paroxysmal supraventricular tachycardia depends if the patient is stable or unstable, and this is important idea because we will see it in many questions about arrhythmia. Is it a stable patient or is it an unstable patient? So what do we mean by this? Is that a stable patient, unstable patient, let's start with this, is a patient, for example, who is hypotensive, in a changed mental status, so he is about to get unconscious or he is unconscious, he is having respiratory distress or respiratory edema. All of these are signs of unstable patient. If we have a patient who has the paroxysmal tachycardia and his condition is unstable, we will use in many cases the defibrillation, which is a method using electrical energy to, let's say, restart the heart rhythm, sets the heart on restart the heart, so the heart can restart on a sinus rhythm, right? It shocks the heart so that the heart can restart again, hopefully with the sinus rhythm, which is starting from the sinoatrial node, atrioventricular node, and so on, and stops the arrhythmia. In Krok, they call defibrillation many names, and you should know all of them. Synchronized cardioversion, electrical stimulation, and electropulse therapy. There is differences between them, but in Krok they use them together, so know all the names. The differences between them, I didn't see that they are significant in Krok. For a stable paroxysmal supraventricular tachycardia, we try to slow the conduction. First by a drug called adenosine. Adenosine converts this supraventricular rhythm to the sinus rhythm. What do you mean by sinus rhythm? This is the rhythm of the heart by the sinoatrial node, which is the heart rate, the normal heart rate between 60 to 100. Also, there are what's called vagal maneuvers. These are the maneuvers that activate the vagus nerve, which, as you know, part of the parasympathetic system and will slow down the heart. One of them is, for example, carotid sinus massage. It activates the vagus nerve. Valsalva maneuver, holding breath while straining, eyeball pressure, all activate the vagus nerve. So here we see two questions in Krok about treatment of supraventricular tachycardia. Adenosine is expected to convert which of the following arrhythmias to sinus rhythm? Paroxysmal supraventricular tachycardia. So adenosine is an effective drug for converting paroxysmal supraventricular tachycardia back to the sinus rhythm. We have another question, which is patient has palpitations, pulsation lasts for 50 minutes and is over after straining while holding the breath. So after straining while holding the breath, this is called Valsalva maneuver, and this activates, can slow down the heart rate, okay, and convert it also to sinus rhythm, alongside with carotid sinus massage or eyeball pressure. These are also part of the maneuvers that can slow down the heart and stop the attack of supraventricular paroxysmal tachycardia. So this was about the first arrhythmia we have here, and we go to the next one, which is a similar one, but it's happening in the ventricle, right? So with a heart rate, when we say paroxysmal, as we agreed, we will the heart rate will be between 150 to 250. But in this case, it's starting in the ventricle, and there will be changes in the QRS. So the QRS, as you can see here, it's a widened QRS, not the narrow one we saw. It's a widening with the QRS. And the treatment is also here, depending if the patient is stable or unstable. Let's see first the questions about the diagnosis and then go for the treatment questions. So basic here, it starts with a person who having myocardial infarction and then having palpitations. Palpitations is a very common symptom in many arrhythmias. His blood pressure is 90/60. ECG attacks during the attack shows extended QRS complexes, right? With the heart of 160. So the heart rate is between 150 to 150, and a widening of the QRS complexes. And this is paroxysmal ventricular tachycardia. Next, we see that the heart rate here is 200, and the ventricular complexes or QRS complex is widened and deformed. The P wave is not changed. So in other words, this is not a atrial arrhythmia. Okay, so this is paroxysmal ventricular tachycardia. Let's see now about the treatment, which is very important, and they are bringing it a lot. If it's a stable patient, as we agreed, like in ECG, you see the pattern of paroxysmal ventricular tachycardia, but it's a stable patient, then you use lidocaine. In international books, you will see that they will use amiodarone, but in Krok, they will choose lidocaine. So this is, we follow what the Krok Center answers are. So in case you get confused, you are reading international book why they use amiodarone, this is just a side note. If it's an unstable patient, as we agreed, then we use defibrillation or the other names for it. We will see them now. Let's see some questions. These are some examples from Krok Center website. And we see here that the patient has a palpitation attack, heart rate 140, widening of the QRS complexes. So it's a paroxysmal ventricular tachycardia. Here, reflex techniques which are used to relieve the palpitations did not work. So what they mean by this sentence, they mean that the techniques or the maneuvers which we use for supraventricular tachycardia, like carotid sinus massage, eyeball pressure, breath holding, did not work. Why? Because these work for supraventricular tachycardia, and here we have a ventricular tachycardia. Vagus nerve have no effect or have no control over ventricular rhythm, have only over AV node and SA node, which is the problem with supraventricular tachycardia. Anyway, here we have paroxysmal ventricular tachycardia, and we have in the questions, we have in the options, sorry, like not two options like lidocaine or defibrillation. As we agreed, I remind you, it's if the patient is stable, lidocaine; if it's unstable, defibrillation. So here in this question, they made it easier for you, and they just brought for you lidocaine, so you choose lidocaine, right? They didn't want you to know if it's a stable or unstable patient, so it's a basic question. You diagnose paroxysmal ventricular tachycardia, you choose lidocaine. But in the next questions, we will see two options, the defibrillation option and lidocaine. So see here with me, it's a patient with myocardial infarction. A lot of questions about arrhythmia, you will see them start with patient having myocardial infarction. This is because myocardial infarction can cause many arrhythmias, including especially ventricular arrhythmias. If a part of the heart is infarcted, then it also can affect the electricity, and normally, or a lot of infarction of the heart happens in the ventricles, so it can cause myocardial infarction in the ventricles, can cause ventricular arrhythmias. So that's why we are seeing a lot, like patient, the scenario starts with myocardial infarction, then paroxysmal ventricular tachycardia. So here they say to you the diagnosis, it's paroxysmal ventricular tachycardia, and see with me, the patient blood pressure is 80/40, so it's a very decreased blood pressure. So the patient is unstable, right? So the patient is unstable, and then for unstable patient, you use a defibrillation technique, which is electrical stimulation. And here we have lidocaine, and why we don't use it? Because lidocaine is for a stable patient. Another example, it's the same question. I think it's the Ukrainian, the version of the question, or the translated version, but it's the basic thing, and the answer is electropulse therapy, which is the same as electrical stimulation, the same as saying lidocaine. Here is a picture to further demonstrate what I mean. This is an unstable patient. He is about to have syncope or loss of consciousness. He's dyspneic. He is having ventricular tachycardia. He's hypotensive. So this is an unstable patient, and we give the cardioversion or defibrillation or electrical stimulation. And see here with me, this is not ventricular tachycardia. This is like more about fibrillation. No, it's ventricular tachycardia. Anyway, so here with me, see here, this is ventricular tachycardia, and when we will administer a shock, this will shock the heart, and then will restart the sinus rhythm. I like this picture because it shows you what's happening, what's defibrillation. So we shock the heart, and then the heart gets a shock, and then restart, and gets right to the back to the sinus rhythm. Okay. We go to the next arrhythmia, and we stay in the ventricles, and this is the most fatal arrhythmia, the ventricular fibrillation. It's like the next stage of paroxysmal ventricular tachycardia, you can consider it. It's basically the ventricle doing like this and not contracting efficiently to pump the blood. It's just fibrillating, right? And it's a very the ventricle is getting depolarized at a very high rate, but not contracting well. Okay, so here you see ventricle is getting depolarized a lot at many places in comparison with normal heart and ventricular fibrillation. The clinical picture is someone who have we cannot measure the blood pressure, the pulse, or the heart sound. It's a very disturbed heart. The patient is unconscious. If it's untreated, it can lead to sudden cardiac death rapidly. It starts also with myocardial infarction, as we said. Diagnosis, it's chaotic, irregular waves of varying shapes and amplitude. So as you can see, this is the ECG of ventricular fibrillation. It's chaotic waves. There is no recognizable P, QRS, or T waves. The frequency is high, very high, between 250 to 300 beats per minute. And the treatment, this is one of the rhythms that is, we consider them as clinical death, so they cause cardiac arrest, and we start CPR, and then until defibrillation device comes. So here in ventricular fibrillation, the treatment is immediately defibrillation. We don't have here a stable or unstable, it's always an unstable patient, and we will start with a defibrillation, and we hope that it comes back to normal. Let's see some questions about ventricular fibrillation. This person with myocardial infarction, he fell unconscious, and the ECG, irregular waves of varying shape and amplitude, so like this. In varying shape, each one is another shape, each one has another amplitude, so this is ventricular fibrillation. Next we see here a patient deteriorated sharply his condition, and in ECG heart sounds before they were staying therapeutic hospital, diagnosis angina pectoris, below palpitations, hair will be deteriorated sharply, heart sounds are dull, heart rate 94, there is no pulse deficiency, blood pressure, episodes of arrhythmia, development of which fatal clinical situation can be assumed. So here they told you that the ECG has a lot of ventricular extrasystoles, which are a lot of extra beats, right? And that's why here it's ventricular fibrillation as well. Next we see a patient with a history of myocardial infarction, complains of pains behind the sternum, palpitation and shortness of breath, progressively increases, blood pressure is 70/40, it's low. During the ECG, the patient lost consciousness, and the ECG reveals chaotic, undifferentiated waves. So the chaotic waves, they use this term a lot, with a frequency of 250 to 300. So what treatment tactics should be chosen? So before the treatment tactics, what is the diagnosis? If it's chaotic waves like we discussed and it's unconscious patient, it's ventricular fibrillation, and the treatment will be synchronized cardioversion, which is another word for defibrillation. Here we have also a question, I think. Here is from book, the difference between cardioversion and defibrillation, just in case you are wondering, but in Krok they don't make a differentiation between them, they are the same for them. Here we see that the patient has undergone a surgery. During the operation, the patient was having ventricular fibrillation, so the first measure should be electrical defibrillation, as we discussed. Also, a similar question is this person is having a circulatory respiratory arrest, clinical death, and we will, ECG shows ventricular fibrillation. What you should do, defibrillation, not lidocaine intravenously. Lidocaine, remember, is for stable paroxysmal ventricular tachycardia. And at the end of the video, I will show you like a table with drugs, all drugs or interventions with the disease, like just in one table, so you can see the differences. Let's also discuss one detail that came in the last exam. Is that, okay, we agree that for ventricular fibrillation we will use defibrillation, right? But if the defibrillation is not successful, it meaning that we make the defibrillation attempt and the rhythm stays ventricular fibrillation, the ventricular fibrillation stays. We make another defibrillation attempt and we assess. It's not successful, we make a third defibrillation attempt. After the third unsuccessful defibrillation shock, if it's 3 times unsuccessful shock, then we should give drugs, injection of drugs, amiodarone and adrenaline together, okay? And we hope then that the heart will restore back to the sinus rhythm. So this is a detail they brought in the last exam, that here we see injured electrician who is in a state of clinical death is being resuscitated. When the ECG, ventricular fibrillation is recorded. According to the clinical protocol, sudden circulatory arrest, it's necessary to administer medications, namely adrenaline amiodarone solution. Here it says translated Ukrainian question, but here they mean when you should use amiodarone and adrenaline together, when it is ventricular fibrillation, in which case after the third unsuccessful defibrillation attempt. Okay, so after the third one. Okay, we go to another fibrillation problem, but this is in the atria. So the ventricular fibrillation, we spoke that it's very dangerous because it's happening at the ventricle level, and the ventricles are the essential part of the heart that's pumping the blood to the whole of the body. So when they are not doing well, the body is suffering, and the clinical death, the person is in a state of clinical death because there is no blood going to the brain, because the ventricles are not contracting well, they are not pumping blood, and so on and so forth. In atrial fibrillation, we have a similar condition. We have atria contracting or getting depolarized at a very high rate. There is a lot of impulses. It's crazy in the atria. But the difference is that we have the atrioventricular node, and this atrioventricular node is filtering these impulses, okay? And not all of these impulses that are happening in the atria are going to the ventricles. So let's say the atria is now depolarizing at 300, 400 times per minute, but what comes to the ventricle is about 100, 150 approximately. So in reality, the ventricles will be getting depolarized 100, 150 times per minute, and they were contracting at this rate as well. So it comes back to normal thanks to the atrioventricular node. But still, it's like a serious arrhythmia that can cause a lot of complications, we will see now, and should be treated. But it doesn't cause like it can be unstable, we will see, but sometimes it's stable, sometimes it's even asymptomatic. So it's a type of arrhythmia originating in the atria, characterized by rapid, irregular impulses. Some of them are conducted to the ventricles thanks to the AV node filtering the impulses. The clinical picture, as we say, palpitations, dyspnea, chest pain. So general symptoms. The ECG will show you the type of arrhythmia. The sinus rhythm is 400 beats per minute. So the rhythm at the atria is about 300, 400, very high, but impulses are blocked at the AV node. So ventricular rate is between 60 to 150, depending on how much atrioventricular node is blocking. Let's go to the ECG and come back to the complications. In ECG, we will see irregular rhythm. So always the distance between the RR waves is different. This is irregular rhythm. See here the difference between RR intervals. There is no pattern. There is absence of P waves. So because the atria is depolarizing at like multiple places, there is no unified one P wave. There is multiple small P waves called fibrillation waves or F waves, or small unevenly sized waves. See here with me, these small P waves, and then one QRS. The small P waves, then one QRS instead of one big unified P wave. These are called fibrillatory waves. Let's look at one. Management is also important. We'll speak about it. Let's see some questions first about diagnosis. So woman having palpitations, etc., and then the pulse is 150, blood pressure is low, the heart sounds are weakened. In ECG, we see missing P waves, small F waves, fibrillation waves, and varying RR intervals, so irregular rhythm. So that's why here we have atrial fibrillation. Ventricular fibrillation, as we saw, is chaotic waves, unrecognizable P or QRS or something. Ventricular tachycardia, they will tell you about QRS complex being widened, while P waves are not affected. Here we see the P waves are the ones that are affected. And supraventricular tachycardia, there are no F waves. There is the P wave overlapping with T. There are ectopic P waves, right? But not fibrillation waves. And yeah, furthermore, it's a regular rhythm. It's a fast rhythm, but it's a regular one. Here we have irregular rhythm. Back to the first page. We have rhythms that are irregular, like that, atrial fibrillation. We have rhythms that are fast but regular, like paroxysmal supraventricular tachycardia. Okay, we continue with diagnosing some cases of ventricular fibrillation. This man having palpitations, and then the most important for me is about the ECG, small unevenly sized wave in place of the P waves, RR intervals unequal strength, so they are the same thing, atrial fibrillation. It's important that RR intervals are unequal length. It means that it's a regular rhythm. We will use it to differentiate it with the atrial flutter right now in the next arrhythmia. Okay, let's go to the treatment of atrial fibrillation. Pay attention with me. This is tricky and it has a lot of details, but we will try to summarize in some words. Atrial fibrillation can be paroxysmal, meaning that it has attacks of palpitations, of dyspnea, of chest pain that is happening every month or two, and it's not like happening daily. Okay, if the atrial fibrillation is paroxysmal, like happening, the attacks happening every 2-3 months, and they end without medical intervention, so without going to the hospital, they end. Then we call them paroxysmal. They are symptomatic. We use amiodarone, and this is the drug they like you to know in Krok. If the atrial fibrillation is completely asymptomatic, so there are no symptoms, it's discovered accidentally during ECG when the patient goes to the doctor for something else, and accidentally there is atrial fibrillation discovered and it's asymptomatic, there is no treatment required. Okay, so the patient had atrial fibrillation and has no symptoms, no treatment required. If it's symptomatic and it's paroxysmal, the patient have palpitations every 1 month or two, then we can prevent these palpitations from happening by giving amiodarone. It's an antiarrhythmic drug. We have other drugs for atrial fibrillation, but they don't mention them a lot in Krok, but they are present in books. So I will mention them. For example, beta blockers. Beta blockers, as you know, decrease the heart rate and can help to control the heart rate in atrial fibrillation. Digoxin is a drug used for heart failure to increase contractions of the heart, of the failing heart, but is also useful in atrial fibrillation because it can slow down the AV conduction. So when I explained to you that the AV node is very important in atrial fibrillation, it filters all of these impulses, and digoxin can help further slow down the AV conduction so that less impulses are going to the ventricles. So it's useful. But in Krok, they prefer amiodarone. In one question, they mentioned digoxin in Krok, and this was a question where there was heart failure with atrial fibrillation, and you can choose digoxin because it's useful for the two conditions. But you choose it in case you don't find amiodarone in the options, because amiodarone is a preferred option in Krok for paroxysmal atrial fibrillation. Now we go for the next case in atrial fibrillation, which is a persistent or acute attack. So either a persistent atrial fibrillation happening every day, the patient's like having daily attacks, we will see, or he comes with an acute attack of atrial fibrillation that making him unstable condition, decreasing the blood pressure, and maybe being unconscious. So these attacks don't end by themselves or don't end without medical intervention. These we call them persistent or even acute attack. If the patient is in stable condition but he's having this acute attack, then we will give him beta blockers, calcium channel blockers, and digoxin. This is in general, but in Krok they want you for the unstable conditions. In case the patient having low blood pressure, chest pain, syncope. So pay attention with me. If it's an acute attack and we have these symptoms, then we use defibrillation. Synchronized cardioversion. This will shock the heart and force the atria to come back to the sinus rhythm. Okay. And we have another question. We will see that now the patient is having daily attacks of palpitations. Okay. So let's imagine the patient came with acute attack of atrial fibrillation. You give him the shock, okay, the atrial fibrillation came back to the sinus rhythm, and that's fine. But let's imagine that he's always having these attacks every day. Then it's useful to give him or to implant a pacemaker, which is a device that's attached to the heart and is always will make the heart rate like the sinus rhythm, will take the position or the job of the sinoatrial node, which is not doing a good job controlling the heart rate. So a pacemaker will control the heart rate and prevent atrial fibrillation. And this is we use it in case of daily attacks to help the patient like having normal atrial rhythm, sinus atrial rhythm. Okay. For prevention of thromboembolism, we will speak about it now. Let's see some questions. This male consulted a therapist about slow discharge for with a small jet. The patient reported no cardiac problems. We see atrial fibrillation or heart rate of 72. There are no signs of heart failure. So the patient reported no cardiac problems, but examination revealed atrial fibrillation. So we discovered it by accident. The heart rate is normal, 72, and as I told you, it can be normal because AV node is doing good job filtering all of these impulses. There is no signs of heart failure. ECG confirmed the presence of atrial fibrillation. We found ECG accidentally we found in ECG accidentally atrial fibrillation. So what is the treatment of atrial fibrillation? So they are telling you it's just atrial fibrillation ECG, but it's not affecting the life of the patient. The patient has no symptoms. That's why it doesn't require treatment. Asymptomatic atrial fibrillation, no treatment. This female patient has 11-year history of rheumatism or rheumatic heart disease. It's a disease affecting valves, for example, mitral valve. Over the last 6 months, this patient she is having paroxysms of atrial fibrillation. So every 2 or 3 months, you have these palpitations, and when they do ECG, it's atrial fibrillation. So what we should propose here in this case, we should propose amiodarone, as we spoke, prophylactic administration or preventive administration of cordarone. Cordarone is amiodarone. Here is another option or another question. This patient 2 years ago suffered a myocardial infarction. He has also heart failure. And they are telling you that the patient is having symptomatic frequent attacks of atrial fibrillation. So frequent attacks, paroxysmal attacks of atrial fibrillation, what we should give him. Pay attention here, this is a heart failure patient and atrial fibrillation patient. But in case you find amiodarone in the options, you choose it. Okay, they prefer this option. There was one question in Krok where there is heart failure and atrial fibrillation, but there was no amiodarone in the options. In this case, you can use digoxin, but in case you find amiodarone, it's a preferred option for paroxysmal atrial fibrillation. Another option, another question, this patient having myocardial infarction and for the last 2 weeks has been suffering from daily attacks of atrial fibrillation. And this atrial fibrillation is causing bradycardia and sometimes vertigo. So this is a patient who's suffering from daily attacks. He needs something on the long-term treatment. So don't tell me about drugs or cardioversion. He needs something long-term to gets it back to the sinus rhythm. So this is a pacemaker implantation, which will always be attached to this patient's heart and will always convert it back to the sinus rhythm. And the last question we have today for atrial fibrillation treatment is a question 2024 booklet. So the booklet that was 4 months ago, the latest Krok 2 booklet. And here we see the patient has a history of hypertension, dizziness and palpitation occur throughout the last hour. The following is observed: blood pressure 80/40, heart rate. So here we see that the patient during the last hour, so it's an acute condition, is having low blood pressure, so it's an unstable patient, and heart rate 150, pulse ECG revealed missing P waves and varying RR intervals. So this is atrial fibrillation. Contraction rate of the ventricles 136, 148. What aid must be provided? So here we have an acute condition of atrial fibrillation, unstable patient. So you choose electrical cardioversion, this is the shock administered to get back the heart back to the sinus rhythm. But why we don't use pacemaker? Because it's an acute condition, right? And we need something right now that gets back to the sinus rhythm. Pacemaker is something we do for the long term, for someone suffering from daily attacks of atrial fibrillation with bradycardia, to help him in the long term. But right now we want an urgent cardioversion because this is an unstable patient and we need to convert him back to the normal rhythm. Now let's speak about one complication of atrial fibrillation, one of the most common complications, which is because atrial fibrillation means the atria is like this. And when it's doing like this, then there is no effective contraction of the atria, so the blood is staying, there is a lot of blood staying in the atria and not going to the ventricles. And this leads to stasis of the blood. What is stasis of the blood? It's meaning that the blood stays a long time in the atria. When the blood stays a long time, okay, and it doesn't move, it has always the tendency to clot, okay, and cause clots. So the atrial fibrillation carries always a risk of formation of a clot. So we have here a clot in the atria, but the problem is that when this clot detaches in the atria and travels in the circulation, goes to the ventricles, then goes to the aorta. And then the next event that will happen or can happen is that this embolus, it's a traveling clot, we call it an embolus, will go and then can block a cerebral artery, will go to the cerebral artery and block it. And this is, we call it thromboembolism complication of atrial fibrillation, okay, meaning that a embolus in the atria was formed and then block a cerebral artery, and what will happen after that, this area of the brain will get no blood and it will have ischemic stroke. So we'll have stroke, an area of the brain that has no blood supply and is now dead, and this is a major event, right? So a stroke is a very complication that we want to prevent in atrial fibrillation patient. So how do we prevent stroke in atrial fibrillation patients? Atrial fibrillation patients should get anticoagulants, so drugs that prevent blood clot formation. But this is not so simple. Not all atrial fibrillation patients get anticoagulation medications. For example, someone who has asymptomatic atrial fibrillation, so no symptoms of atrial fibrillations, and no such risk factors, if these risk factors increase the likelihood of clot formation. If we find, for example, someone who has no diabetes mellitus, he is young, he has no hypertension, and so forth, he doesn't get anticoagulants. But in case he, for example, he had a stroke before, he had atrial fibrillation and he had stroke one time in his life, this is enough to get him anticoagulants for the as a prevention for further clot events. For example, this is the score, and someone who got a stroke, one-time stroke before, this is already 2 points. And if someone has 2 points, this is already, he has a higher stroke risk, and he gets oral anticoagulants. If someone has 0, then he gets nothing. If someone has 1, he gets aspirin. Let's see some examples of this. For example, here, what should be prescribed as a secondary prevention drug for a patient with atrial fibrillation after an ischemic stroke caused by cardiac embolism? So this patient already has a stroke, and we want to prevent the second stroke. So already has 2 points, and this means that the patient should get oral anticoagulants, right? Not aspirin. Aspirin is 1 point, which is, for example, if someone is just old age and has atrial fibrillation, but here we have a stroke event. Yes, so these were the questions about atrial fibrillation. We go to the next arrhythmia, which is also in the atria, called atrial flutter. It's also abnormal focus in the atrium, discharging very rapid regular impulses, but the difference is that they are regular impulses. You can consider it as 1 degree, it's a milder version of atrial fibrillation. It's atrial flutter. It's still high rate, but it's a regular rate, and still the atrioventricular node is filtering a lot of impulses and not allowing them to go to the ventricles. The heart rate is about 150, and the ECG is most important. The P waves are replaced by flutter waves. It's called atrial flutter, so they will call these waves flutter waves. They are big F waves. So in atrial fibrillation, we call them small f. In atrial flutter, they are big wave F, and sometimes we call them sawtooth waves. So they look like sawtooth, like this. And as you can see here, the QRS is normal and regular. Here we have regular RR intervals. This is an important difference between atrial flutter and atrial fibrillation. Atrial flutter is regular, atrial fibrillation is irregular. The treatment here is more simple. Stable, give beta blockers, calcium channel blockers. This will slow down the heart rate. Unstable, cardioversion, and that's it. Let's see one example in Krok Center website about it. Old man undergoing treatment for myocardial infarction. Palpitation suddenly developed. Heart rate is 140. In ECG, there is no P waves. Instead of it are big F waves with the same shape and amplitude, and the QRS complex is not changed. So when they tell you big F waves, okay, not small F waves of unevenly sized. So the F waves are unevenly sized, right? They are irregular, unevenly sized, and these are called fibrillation waves. But F waves are the same shape and amplitude. Okay, they are visible, they are regular. So this is atrial flutter. Next we have extrasystoles. These are simply extra beats. So when the heart is contracting perfectly, there is PQRST, PQRST. See here. There is nothing wrong with the heart, but there is one time in which the ventricles, for example, contract out of the, like, by themselves, without outside of the order. It's like the heart is contracting at like or depolarizing normally, and then we have a extrasystoles, an extra beat basically. And this is extrasystoles. It can happen due to physiological conditions like emotions or excessive caffeine. Can have extra beat, can excite the heart, or pathological like digoxin toxicity, which increase the heart contractions and can also cause extrasystoles as a side effect. Maybe you have extrasystoles but you don't know it, right? These are asymptomatic, and maybe I have them and I don't know them. These are asymptomatic, can be asymptomatic. Maybe we have someone have them once per month and he doesn't notice, right? So they can be, as I said, physiological, but sometimes they cause palpitation, they cause symptoms. So this also affects the treatment. If it's an asymptomatic patient, we don't give them any treatment. We will see one question about them. If it's asymptomatic, we give them amiodarone. The ECG is a wide, bizarre QRS. If we are speaking about extrasystoles in the ventricles, it's then a QRS, because the ventricles, when they contract or when they depolarize, it's what represents an ECG, QRS. So when there is a ventricular extrasystole, it will be an extra QRS, not preceded by P wave and not followed by followed by compensatory pause. So because it's a ventricular extrasystole, so it will be just QRS without a P wave before it. So here we see QRS, just this. This is the ECG of ventricular extrasystole. We have two questions about the treatment. Here, patient with post-infarction cardiosclerosis has frequent heart rate disorders and lower extremity edema. Pulse is 95, irregular. He has extrasystoles. I think here it's like 12, I think, or 10 to 12. 10 to 12, not 1000 per minute. 10 to 12 extrasystoles per minute. So this is quite a lot of extrasystoles, like 10 extrasystoles per minute. And they repeat themselves, frequent ventricular extrasystoles. What antiarrhythmic drugs are advisable? So here we have clearly asymptomatic extrasystole that is happening a lot per minute. So we need something to prevent them. This is amiodarone. And here in this patient, we did a 24-hour ECG monitoring. This is a device that is like can record the heart ECG for 24 hours. We give it to the patient and it's attached to the heart, and then we tell the patient to go home and then come back after 24 hours. It will record the heart activity for 24 hours, and then the patient come back. We saw that he has 27 supraventricular extrasystoles. Okay, but the patient, we didn't see that the patient say about any symptoms. They were discovered due to 24-hour ECG monitoring and accidentally, right, during his life and so on. So these are asymptomatic extrasystoles, and there is no pharmacological correction needed. This was 2023 July booklet, so recent booklet. We go to the next arrhythmia, and this is we have this, and then atrial block, and then atrioventricular block, and we will finish. Wolff-Parkinson-White syndrome. There was one question about it in Krok, and it's a syndrome in which instead of the heart following the usual path of conduction, this is sinoatrial node, AV node, so forth, it will follow an accessory pathway that connects the atrium and ventricle and bypasses the atrioventricular node. So the rhythm will go from atria to ventricle directly without passing through the atrioventricular node. This is Wolff-Parkinson-White syndrome, and it causes ventricular pre-excitation impulse. It can be asymptomatic, okay, so it's not a big deal that there is atrial depolarization and ventricular depolarization immediately without AV node holding the impulse, but it can be also causing palpitations. It can be life-threatening, however, if it's combined with atrial fibrillation. So imagine we have atrial fibrillation here, a lot of impulses in the atria. Normally, a lot of them are filtered by the AV node here. The patient will have less impulses going to the ventricles, so the ventricles will contract depolarize at a normal or relatively normal rate. But if we have Wolff-Parkinson syndrome combined with atrial fibrillation, then a lot of impulses will go to the ventricles. All the impulses in the atria will go into the ventricles. AV node will be we will bypass it. Okay, so atrial fibrillation will convert to ventricular fibrillation. We will have a lot of impulses going to the ventricle, and it will convert to ventricular fibrillation, which is very serious, as we said. So this is one scenario that can happen in Wolff-Parkinson syndrome if it's combined with atrial fibrillation. The ECG of Wolff-Parkinson syndrome is the most important. They ask a lot about it. It's because we have a impulse going directly to the ventricle like this. So we have something called delta wave, which is, you can say it, premature excitation of the ventricle, which doesn't happen in case we have AV node. So delta wave. And because we bypassed the AV node, then the part of the ECG representing the AV node will be shortened. So we have short PR interval. The PR interval is the interval between P wave, okay, and the R wave normally. But here, because we bypassed the AV node, then it's shortened. PR interval shortened. And there is widened QRS. It's here a mnemonic WPW, Wolff-Parkinson-White syndrome. So W means widened QRS, P short PR interval, W wave delta. Treatment, it wasn't asking Krok, but I wrote it anyway. Stable procainamide is an antiarrhythmic, unstable cardioversion. Long-term treatment is to close this accessory pathway. We want to close this accessory pathway. They do it by using a catheter that uses electrical energy, and it closes this additional conduction pathway. This is how this catheter looks like. Let's see one example about this in Krok. Sorry, it was actually the question about Wolff-Parkinson syndrome is about the treatment. So it was actually asked. This patient suddenly had a seizure during the examination, a military-based palpitation. With the ECG, the following is observed. The rhythm is correct. The heart rate is 180 per 1 minute. PQ interval is 0.08. QRS is widened. PQ or PR interval is actually here shortened. This is like decreased PR interval. There is a delta wave. So we have all the signs of Wolff-Parkinson syndrome: delta wave, shortened PR interval, and widened QRS. So it's a Wolff-Parkinson syndrome. What type of invasive intervention is indicated in this case? So they told you right away, we want an invasive intervention. We want a surgery. So we skip that, the temporary or medical treatment. And in this case, we want a ablation of the additional conduction pathway, or closing this additional conduction pathway by the catheter. The last arrhythmia we will have here is atrioventricular block. It's a block in the atrioventricular node. The atrioventricular node delay the impulse that's going from the atria to the ventricle. So here AV node delay the impulse and sometimes doesn't even deliver it. This is we call atrioventricular block. And depending on what happens, if it's just a small delay, then it's first degree. If it's a delay with sometimes not delivering the impulse at all, so we'll have a drop of the QRS complexes, then we have second degree. If it's complete block, meaning the atrioventricular node does not deliver any impulses from the atria to the ventricles, then we call it third degree or complete block. Krok, they ask more about the third degree, so let's see this one. But you can read and note, write in your notes about the second degree and the first degree. So in the third degree, we have all impulses from the atria don't reach the ventricles. We have complete dissociation between the atria, which is P wave represented by P waves, and ventricles, which is QRS waves. The heart rate, for example, in the atria will be something, and the heart rate, the ventricular rate, so the atrial rate will be something, and the ventricular rate will be something else, because the atria will be contracting or depolarizing at one rate, and the ventricle will be depolarizing and contracting at another rate. There is complete dissociation between the two. There is no connection. So for example, let's see this ECG We see here P waves occurring at random places, not related, they are not connected to the QRS. So, and the QRS also occurring at random places. Okay, so this is atrial rate, ventricular rate is dissociated. This is of course not always like this, not always like, okay, the ventricle is contracting and there is no problem. Sometimes the ventricle does not get depolarized, and this is, we call it Adams-Stock syndrome. When the ventricles don't depolarize and then will not contract and will not pump any blood to the brain, then there is sudden loss of consciousness or syncope or dizziness, right? And this is called Adams-Stock syndrome. And when you see in the question, they ask you about atrioventricular block question, and they will tell you in the question there is loss of consciousness, dizziness, or syncope, then it's most likely third degree or complete heart block. That's the most severe. For emergency treatment for this condition, we give atropine. Atropine improves conduction of the AV node, and for long-term treatment, we need a pacemaker that is always will ensure the conduction of the impulses across the atria and the ventricles together. Let's see some questions. Here we see the patient has dizziness, heart rate 35, blood pressure low. We see that the P waves are not associated with the QRS complexes. There is a different rhythm of atrial ventricles, varying location of the P wave in relation to the QRST complex. So the P wave are not connected to the QRST complex. This is atrial complete, atrioventricular block, third degree. This patient has signs of Adams-Stock disease, which is a disease that is happening in the third degree atrioventricular block when there is no contraction of the ventricles and there is no blood going to the brain. There is dizziness, loss of consciousness. So we need as an emergency aid atropine. Here we have a patient having pain and rhythm intermissions. ECG result, heart rate 250, deformation corrects complexes. There is a complete dissociation between P wave and QRST complexes. So this is what I want to say. Which of the following will be the most effective treatment? So when there is complete dissociation between P and QRST, this is implantation of the artificial pacemaker, the most effective treatment for the long term. And here we have another question. Dizziness, short-term periods of unconsciousness. So this doesn't happen in first degree. First degree is even asymptomatic. It's just slight delay of AV node conduction, but there is always conduction in the atrial ventricles. But when third degree, there is sometimes not even all the impulses not conducted, and sometimes the ventricles are not contracting at all. So the patient will become unconscious. Heart rate's 40, etc. So they didn't here tell you anything about the P being dissociated from the QRST. The most important thing that, as I told you, is this piece of information. The short-term periods of unconsciousness, this will give you the answer that it is AV block of the third degree. And we have another concept, the last concept about third degree heart block, that has two types, proximal or distal. So depending on where we have the block, it can be AV node, directly AV node, or a little down. So if the atrial impulse is blocked at the AV node, so here is the block, here at this black line, then the ventricles will depolarized thanks to the bundle of his starting the impulse, which is this bundle of his is a part of the conduction system. They will take the lead and they will depolarize, okay? And bundle of his can give a rapid depolarization, fast depolarization, which will be represented by a narrow, very important, narrow QRS complex, okay? But we call it proximal third degree heart block, meaning that the block is happening at the proximal level, at a higher level. But when the heart block is happening at the distal level, at a, like, not at the AV node directly, but a little lower, this is where we have the block happening at the His bundle, right? Or below even the His bundle. And this means the ventricles will be, who will take the lead in this case, will take the lead some cells in the ventricles, okay? So the ventricles themselves will be the pacemaker, and then the ventricles themselves being the pacemaker, they are not like will give this fast depolarization, such as the bundle of His. So the QRS complex in a distal third degree heart block will be widened. Okay, so this is the difference between proximal third degree heart block and distal third degree heart block. Proximal will have narrow QRS, and you know why. While in distal we have a widened QRS. In addition to that, we have complete dissociation between P and QRST. This is happening in both types, but we are just stating the difference between a block at the proximal part, this is AV node, or at the distal part. And this is one question Krok about it. 52-year-old patient having vertigo and loss of consciousness, typical for third degree heart block from anesthesis, myocardial infarction, etc. On the ECG, pathological Q wave and AVF lead 3. This is like signs of myocardial infarction, not important, but P waves and QRS complexes are not related to each other. So this is the third degree. You cross the other options, which is first degree or second degree. The QRS complex is narrow. QRS complex is narrow. So this tells you what? This tells you that the block is happening at a proximal level. So this is the right answer. Proximal type, third degree block. So this is the answer for this question if you see it in Krok Center website. So these were the arrhythmic diseases or arrhythmia. This is a table combining the arrhythmias and their treatment. It's useful to have them side by side so that you can solve them and you don't get confused with many scenarios, with many details. So yes, revise them good because there are a lot of questions about them. And this is a table where you have the drug, okay, and its uses in all arrhythmias. It's also useful. And in case of any questions, feel free to ask me, or if you want to join our course for Krok 2 preparation with Krokology, then feel free also to contact me in Telegram. Thank you, and until next time.